Good morning, everyone. It's my pleasure to introduce Dr. Meghan Hupp. I know everyone probably knows her well in the audience. So Dr. Hupp grew up in southern Minnesota in Claremont, and she attended St. Mary's University where she obtained a bachelor's degree. She subsequently went to Penn State and studied medical school there, and she was really committed to pathology, and so we were really lucky we were able to recruit her to our APCP program. And so Meghan came and we had the opportunity to work with her in HEMATOpath for a number of years as a resident, and she was extremely productive, did a number of projects with Dr. Corville. And she's one of two of our residents that have been able to win both the abstract award and the paper award for the Ernst Research Award. And so when Meghan was early in her residency career, I asked her if she was interested in becoming a junior member of my CAP committee. So we do a lot of the PT for flow cytometry, and Meghan's been a really great fit for us and probably been one of the most productive junior members we've ever had. So Meghan's going to talk to you today a little bit about what her role was like as a CAP member, and a little bit about the CAP and how proficiency testing and the laboratory accreditation program can be used to influence and improve testing for patients with hematolymphoid neoplasms. And so, Meghan, I'm really proud of your accomplishments, and I look forward to your talk. Thank you very much.
Thank you, Dr. Lennon. That was a very kind introduction. As he said, I'm the Hematopathology Fellow this year. So I have no disclosures other than I am a member of Dr. Linden's committee, which may cause me to like the College of American Pathologists a little more than maybe other people do. So today we're going to talk about what the CAP is, and within that, what the LAP is and PT, proficiency testing. We're going to review minimal residual disease testing by flow cytometry. We'll look at recent research by the committee and discuss subsequent PT and CAP checklist changes. And then for our residents, just review what junior committee membership is and what it can afford you. So first, the College of American Pathologists, or as I will refer to it as the CAP or CAP. It was created in 1946. It's the largest organization of board-certified pathologists in the world, and its mission is to foster and advocate for excellence in pathology and lab medicine, which it accomplishes through supporting members, ensuring laboratory accuracy, and influencing public policy. Part of fostering excellence and ensuring accuracy are the Laboratory Accreditation Program, or LAP, and Proficiency Testing, or PT. So LAP may be better recognized as checklists and inspections. It is the most popular method of maintaining compliance through CMS, or with CMS through CLIA. Other options include COLA, which is the Commission on Office Laboratory Accreditation, or directly through CMS. Proficiency testing will be further explained in a minute, but CAP is the chosen PT provider for over 22,000 labs worldwide. This means that we can compare PT results from LAP accredited labs with non-LAP accredited labs. So in January of 2019, I joined the Diagnostic Immunology and Flow Cytometry Committee, or DIFCs, as we call it, which includes 22 members, including me, and 2 CAP staff members, and is chaired by our very own Dr. Linden. Members on the committee include medtechs, community and academic pathologists, researchers, trainees. We have a lot of work. Flow cytometry and immunology are both such large disciplines that we split the work into 2 clusters. The immunology cluster is responsible for about 80 analytes or assays, such as these on screen. This is only a very small fraction of them. The bolded analytes are regulated analytes. This means that they are of moderate or high complexity, are non-waived, and require participation in a PT program, which consists of 5 challenges per mailing and 3 mailings per year. Scoring less than 80% on 2 surveys in a row means failure and corrective action must be taken by the lab. Failures after this means that patient testing has to cease for a given time and that labs must prove that they have improved their methods and are reliable. The non-bolded analytes are not regulated and subscription to PT is optional. However, by CMS ruling at inspection, all analytes and assays must have quality assurance methods performed at least twice a year. So PT participation is a convenient and cost-effective way to comply with this. I am more active within the flow cytometry cluster. These are the assays that we're responsible for, none of which are regulated. Because they're not regulated, we don't need 5 challenges in 3 mailings per year. We typically do 2 mailings with 2 or 3 challenges per mailing. So let's transition to flow cytometry and its role in minimal residual disease testing, or MRD. First, a quick review on flow cytometry. Let's say that the sample we want to test is in the peripheral blood. To the sample, we would add 10 fluorochromes attached to antibodies that are specifically targeted for cell surface antigens, such as CD45. Unbound fluorochromes are washed away, and the sample is passed through a fluidics chamber designed to allow 1 cell at a time to pass through a laser beam. The fluorochromes become excited and emit light of specific wavelengths. Each cell may have several different kinds of fluorochromes attached. For example, let's say we have a population of cells that have the antigens CD45, CD19, and CD20 expressed, but lack CD3, CD5, and CD10. This would best fit with the normal peripheral blood component of B cells. We can also get data about the physical properties of the cells using forward scatter and side scatter. Larger cells tend to have more forward scatter, and those with more cytoplasmic complexity, like increased granules, have more side scatter. This first CD45 versus CD38 plot is shown in density color, with red showing the highest density of events and blue or black with the lowest. Plasma cells typically express CD38 and 45 brightly. So we know that the circled cluster here probably represents plasma cells. Compared to the small populations normally seen, this looks like too many plasma cells. So we can draw a gate around it and use other markers to investigate. Now we have taken only the cells from that first gate, which we called CD38. While bright for CD38, these plasma cells are heterogeneous dim to negative for CD138 expression. CD19 is negative, and CD56 is brightly positive. This immunophenotype is consistent with neoplastic plasma cells. To clinch the diagnosis, let's plot kappa light chain against lambda light chain. In a normal or reactive plasma cell population, we should see a mixture of kappa and lambda. Here, virtually all the neoplastic cells are lambda monotypic. So this flow study is an example of one that was able to aid in the new diagnosis of a lambda-restricted plasma cell myeloma. Minimal residual disease testing is used in hematolymphoid neoplasms to describe residual or recurrent disease after treatment that's at such a low level we can't see it by light microscopy. In most neoplasms, MRD status is prognostic and it may guide treatment. There are several ways MRD testing can be performed, the most common of which are flow cytometry, PCR for specific genetic aberrations, clonality testing like immunoglobulin or T-cell receptor restriction, or a combination of these methods. MRD testing by flow cytometry uses aberrant immunophenotypes that are identified on a thorough flow cytometric immunophenotyping assay at diagnosis, when the disease burden is presumably high and easy to identify. Flow cytometry can be quicker, cheaper, and apply to more patients than the other methods, but some neoplasms are better suited for the other methods. For example, chronic myeloid leukemia is monitored with PCR of the BCR-ABL transcript, which is specific and sensitive to 0.01%. So let's take a look at how we use flow cytometry in MRD testing. Let's use this 64-year-old female as an example case to apply what we've learned so far. She has a history of IgG kappa plasma cell myeloma and is status post-auto peripheral blood stem cell transplant. Her CBC with differential is remarkable for only a slight macrocytic normochromic anemia. A small monoclonal IgG kappa was found in her serum, in addition to an increased kappa to lambda ratio. The urine showed a mixed proteinuria without a monoclonal peak. The flow cytometry of a bone marrow biopsy is usually ready for our analysis earlier than the trephine core biopsy sections, so let's look at the flow first. Using the CD38 by CD45 plot, we can select for what are likely plasma cells, CD45 positive and bright CD38 positive. Taking these events and plotting them against forward and side scatter, we can see that the populations here are relatively similar in side scatter or cytoplasmic complexity and heterogeneous in forward scatter, which is size. Again, if we take the PC gate from our first plot and plot them against CD56 and forward scatter, we see this population that has bright CD56 and is quite large. We know from the patient's diagnostic flow cytometry that this is where her myeloma cells fall. So we can draw a gate around what we expect to be the residual disease. So you may notice that there are some different color schemes going on here. We can color each population by gate if desired. For example, if we want to see all the possible myeloma cells in relation to the normal plasma cells, we can color them black. And we can also make the event points larger in cases with rare events, which is why each black dot sort of looks like a giant pixel. The cells have CD19 and CD45 expression similar to the background plasma cells, and all of the suspicious events are kappa monotypic. This is completely consistent with her previous diagnosis, but there are only 17 events in the whole study, or less than 0.004% of events, which is below our lower limit of detection. Looking at the sections of the trephine core biopsy, we can see that it's appropriate cellular for age. CD38 on the majority of the core shows scattered background plasma cells without clustering, although we need to take a closer look at this edge. There's a nodular aggregate of cells with a moderate to abundant amount of cytoplasm. On our 50x objective, we can see that it has the classic morphology of plasma cells. We have eccentric nuclei with moderate amount of cytoplasm, a perinuclear HOF, and chunky clock-faced chromatin. We can also see features of malignancy with slightly increased atypia and binucleation. These cells all express CD138 and are kappa monotypic. So this case had a normal cellular marrow with trilineage hematopoiesis and a single sheet of kappa monotypic plasma cells at the very edge of the biopsy. This highlights a myeloma pitfall. It is inherently patchy in the bone marrow. For this reason, when we're at diagnosis, we usually get bilateral bone marrow biopsies to increase our chance of actually getting diagnostic tissue. So the flow cytometry was signed out with a comment. There is a minute population of kappa-restricted plasma cells identified by aberrant expression of CD56, similar to that reported previously in this patient. However, the cells are too few for a definitive diagnosis or below our limit of detection. Since this diagnosis, the patient has been maintained on bortezomib and zoledronic acid. The provider may elect to follow up on shorter intervals due to this flow result. We will return to discuss the establishing of a lower limit of detection in a moment. We've seen how small populations can be identified on flow cytometry, and hopefully we understand the principles. Well, so what? Just because we can detect it doesn't mean it's clinically relevant. So luckily we have a lot of data to turn to in this regard. To highlight the importance of MRD, let's look at some of the landmark studies regarding MRD in B-ALL. So this paper was published in Blood in 2008 about the COG P9900 lymphoblastic leukemia study. There were over 2,000 patients included, and the goal was to see if MRD status after induction therapy could help risk stratify consolidation therapy. For the induction therapy, all patients received what was standard for their pre-induction risk levels, which was based off genetic aberrations, demographics, and other clinical variables. For example, those with a TEL-AML1 fusion receive standard care, as this 1221 translocation is a good prognostic marker. In contrast, those with KMT2A rearrangements or CNS involvement receive intensified regimens, which included lengthened consolidation chemotherapy regimens and the addition of CNS irradiation. Here's what they found. Those negative for MRD had significantly better relapse-free survival, both early after treatment and later. Remember that this includes all patients, including high-risk patients, exemplifying how MRD is an independent risk marker. An important note for looking at MRD studies, always check what they define as MRD, quote, negative. These authors used 0.01% as a cutoff. This study also showed that the level of disease is prognostic. Those with less than 0.01% had better prognoses than those with 0.01 to 0.1%, which was better than 0.1 to 1%, which again was better than more than 1%. The authors proposed that the reduced probability for event-free survival in the groups higher than 0.01% was so marked that these patients should receive additional or intensified consolidation therapy. So let's look at the literature for myeloma, since we've already talked about myeloma. This paper, also from Blood, also in 2008, had over 500 myeloma patients that were assessed for MRD after autologous stem cell transplant. They used the same MRD negative definition as the ALL paper, and they also found that those with detectable disease had poorer outcomes than the MRD negative patients. In contrast to ALL, MRD is currently just a prognostic marker. It doesn't guide treatment in myeloma. Both those with stable low-level disease and those that are MRD negative usually are maintained on lenalidomide therapy or a different, whatever maintenance therapy works for them. While progression or another event typically triggers treatment intensification, usually with reinduction and or a bone marrow transplant. The clinician may choose to reevaluate the low-level MRD positive cases at shorter intervals. The different management in low-level MRD patients with myeloma versus ALL is partially due to the different nature of these diseases. Myeloma is typically thought of as an incurable disease unless you get stem cell transplant. So management of symptoms may be an adequate goal of care, whereas ALL is a highly curable disease, but recurrent disease or relapses can be catastrophic. So we have now shown that minimal residual disease testing is important for prognostication and therapy. We've also touched on the CAP's role in ensuring accuracy in the laboratory. So let's delve deeper into what one committee can do to help foster MRD analysis by flow cytometry while promoting best practices. In response to the rise in MRD testing popularity, this 4-question survey was dispersed to those receiving the A mailing or the first mailing of the FL3 survey in 2014. FL3 is just the code for this specific PT program. The questions were, do you perform MRD testing? If so, what for? What's your lower limit of detection? And if PT was available for MRD, would you participate? What did they find? Well, about a third of laboratories subscribed to this flow cytometry PT product were performing MRD testing. And lymphoblastic and myeloid leukemias were the most frequent indications. When reviewing reported analytical sensitivities, a wide range was noticed. Except for ALL, 0.1% was the most frequent lower limit, where ALL most commonly had a limit of 0.01%. There were also a handful of people who reported other. The write-in answers for lower limit of detection or sensitivity ranged widely. ALL ranged from 0.0002% to 1%, and the other neoplasms range from 0.001% to 1%. Arguably, 1 in 100 cells is not really minimal residual disease testing. As we saw from the COG study, calling someone with 0.5% leukemic cells as MRD negative does not benefit that patient, as they should receive intensified consolidation therapy. These findings highlight something important. MRD negative at one lab may not be the same as MRD negative from another. With the goal of standardizing MRD testing by flow cytometry, the DIFCs added 2 new items to the rare event flow cytometric assays section of the CAP checklist in 2015. The first states that the lower limit of detection must be validated by performing dilutional studies of known patient samples or reference samples. And the second states that this lower limit of detection must be clearly stated in the final report. As an example, this is how we currently report our lower limit of detection on myeloma MRD reports. So let's take a quick aside and discuss dilutional studies and how to validate a lower limit. As an example, let's say we have a patient sample that we know has 0.8% kappa-monotypic plasma cells. We can then make a series of dilutions and perform flow cytometry on all of them. The results may look like this. With a neat sample, the neoplastic samples are detected at 0.8%. They could also be detected reliably at 0.1% and 0.01%. But at 0.001%, the population of interest was not able to be reliably detected. Therefore, our lower limit of detection is the last concentration we were able to reliably detect, obviously with replicates, which for us is 0.01%. So back to the 2 new checklist items. The committee introduced them in 2015. How have they worked? Well, we decided to take an in-depth view at fewer disease with this follow-up survey. B-ALL and myeloma were chosen as there are published criteria for high sensitivity flow cytometric MRD testing from well-respected international clinical groups. As previously discussed, the COG endorses a cutoff of 0.01% for B-ALL. For myeloma, the International Myeloma Working Group endorses a limit of 0.001%, as does the International Clinical Cytometry Society, though they state that 0.01% is currently accepted as the minimum clinically relevant and routinely achievable threshold, but that 0.001% is preferred and should be the goal of laboratories. So now that we've chosen which disease to look into, the committee sent out another voluntary survey with the A mailing of the 2017 FL3 survey. The questions that were asked included, do you perform rare event analysis or MRD testing? If so, for what? The next 2 questions are targeted specifically towards compliance with the 2 new checklist items. How do you calculate the lower limit of detection, and do you report it in the final report? And then finally, the lower limit of detection, the typical number of collected events, and the method used were queried for both myeloma and BALL. There's no FDA-approved flow MRD assay, so all are laboratory-developed tests, or LDTs. The EuroFlow panel is endorsed by the International Myeloma Working Group, and the COG-approved BALL method from 2000 is widely used. For COG trials, laboratory testing was previously centralized to 1 or 2 labs, but it's now decentralized, but use of these methods is still required. Oh, here are the papers, sorry. So this is where I come into the picture. Our manuscript with the lengthy title of Participation in the College of American Pathologists Laboratory Accreditation Program Decreases Variability in B lymphoplastic leukemia and plasma cell myeloma, flow cytometric minimal residual disease testing. Whew. It has been accepted to archives and can be found on their website in an early online release form. Compared to 2014, fewer labs are performing MRD testing in 2017. There was no significant change in the proportion of labs performing MRD for B-ALL or myeloma. More labs that participated in LAP validated their lower limit of detection with dilutional studies than those that did not participate. There was no significant difference between LAP participants and non-participants if they reported their LLOD on the final report, though a higher proportion of LAP participants did report it. Interestingly, those that are participating in LAP but answered this way, they would not be in compliance with the rare event analysis checklist items, and if they continue to not report it, at their next peer inspection, they should receive deficiencies. So myeloma had a higher median of events than BALL. However, BALL's minimum and maximum were higher than myeloma's. The flow cytometric method varied widely for both diseases. More labs selected other methods instead of the EuroFlow or COG approved methods. However, within the other category, no single test was used more frequently than EuroFlow or COG. LAP participants were most likely to use 0.01% as the myeloma cutoff, while non-participants used 0.01%. The EuroFlow method, endorsed by the IMWG, was most likely to be used in a lab that had the 0.01%, where other methods were at 0.1%. ICCS methods were within the other group, and recall that they said a 0.01% cutoff was acceptable. For BALL, 0.01% or 1 in 10,000 cells was the most popular cutoff across the board. So conclusions from this study. Fewer labs are performing MRD testing on BALL and myeloma compared to 2014. This is possibly a result of the checklist items causing poor performing or non-compliant laboratories to discontinue MRD studying or testing. A large majority of the laboratories perform dilutional studies to validate their lower limit of detection or sensitivity and report this on their final diagnostic report, and LAP participating labs are more likely to do each. An increased proportion of labs report LLODs matching recommended cutoffs recommended by the COG and International Myeloma Working Group, but a large range of lower limit of detections remain. There's 100,000-fold differences in BALL reported LLODs and 1.5 million-fold in myeloma. So these papers and the actions taken from them are the results of an ideal demonstration of how the laboratory accreditation program can change with new data and new practices, and how it improves clinical care. Now, let's take a look at how proficiency testing products are also changing with the times to promote education and ensure laboratory excellence. This was presented at the USCAP or USCAP meeting in March. New wet challenges for flow cytometric detection and characterization of myeloma were introduced in early 2018, and there have since been, at the time of the poster, there had been 4 mailings. In a wet challenge compared to a dry challenge, the CAP committee sends out tumor cell line samples, sometimes diluted in whole blood, other times in a diluent, which must be processed and analyzed and then interpreted. There are obviously many more variables than with a dry challenge, in which gated flow cytometric dot plots are sent out with pertinent clinical and lab data and a whole slide image. Wet challenges allow labs to verify the accuracy of their flow cytometry methods and interpretation of the results, whereas dry methods essentially just evaluate their interpretational skills. During these 4 mailings over 2 years, 91 to 106 labs subscribed to this product. Overall, there was excellent performance. Almost all were able to correctly identify neoplastic plasma cells when they were present in wet challenges. Laboratory agreement was over 80% for most fluorochromes. 90 to 97% of labs were able to correctly diagnose small neoplastic plasma cell populations on dry challenges, although one dry challenge was unable to meet consensus, as less than 80% chose the intended response, and we'll come back to that in a second. Laboratories that have been performing well with this new PT product excuse me. And we intend to introduce new wet and dry challenges for MRD testing of myeloma. So let's take a look at a dry challenge from the previous myeloma PT mailing. The clinical history is a 71-year-old male with a history of diabetes and hypertension. CT showed diffuse lytic bone lesions. SPEP and IFIX were negative for an M spike. And the serum free light chain concentrations were elevated, but the ratio of capital lambda was normal, and UPEP and IFIX on the urine were negative. The whole slide image included with this case showed increased plasma cells with atypical morphology and binucleation. So this first plot uses density map coloring. And it shows a relatively large abnormal population that has bright CD38 and is slightly dim for CD45. This population is then color gated in black in the subsequent plots. The population demonstrates negative CD19, heterogeneous CD20. It's CD38 positive, as we saw up here, but negative to dim CD138, although higher than the background B cells, and heterogeneous CD56. The intracytoplasmic kappa versus intracytoplasmic lambda plot demonstrates a polytypic background of plasma cells and B cells in blue and pink. And our population of interest has no cytoplasmic light chain expression. Additional provided information indicate that the plasma cell tube was repeated 3 times, once with the same set of antibodies and twice with different antibody combinations, including changing polyclonal and monoclonal and using different vendors, and there was still the same result. So laboratories would put all this information together, fill out the answer form provided with the PT materials, and mail it back to the CAP. After the testing period ends, a participant summary report, or PSR, is sent to all participating labs with the results. For each challenge, the results are discussed and the participants are briefly educated about the disease and how to improve performance. Remember that consensus is defined as 80% or higher on of agreement. So consensus was reached for all fluorochromes in this study. The most favored interpretation was as intended, a non-producer myeloma. However, consensus was not reached. The biggest detractor for the correct answer was a non-secretor myeloma. So let's review the difference. While both would have no monoclonal protein detected in their serum or urine, non-secretory myeloma cells do make the immunoglobulin, but they're unable to excrete it extracellularly. So these would be able to be detected by IHC immunohistochemistry or in situ hybridization and by flow cytometry after we've added agents to permeabilize the cell membrane. Whereas non-producer myeloma has no immunoglobulin in its cytoplasm because, of course, it doesn't produce any. Including a difficult or tricky case like this may be seen by some as cruel and unusual punishment. However, the CAP sees it as an opportunity to educate laboratories while allowing them to make the wrong choices without adverse events affecting real patients. To show how a system like proficiency testing can educate laboratories, let's take a look at this paper from 2018. One reference lab and 7 labs that were experts in B-ALL MRD were recruited. The first mailing included list mode files for 15 cases, including low-level positives and negatives. List mode is essentially just the format that raw flow cytometry data is saved as. The discordance rate at this point is 26% among the laboratories. The reference lab then analyzed each lab's answers and provided educational feedback. And then a new set of list mode files were distributed. The discordance rate dropped substantially, providing evidence that this format can provide valuable education. So we're currently in the process of analyzing data and writing a manuscript on MRD testing for B-ALL alone. We're going to look at the last 2 years of data since our B-ALL MRD dry challenge was debuted in 2018. There are 12 total challenges in 2018 and 2019. We had 55 to 80 labs participating in each mailing. The negative cases, or those without a measurable population of leukemic cells, proved to be the most challenging, generally due to labs misidentifying a regenerating hematogome population as leukemic blasts. Hematogones are normal lymphocyte precursors, B-cell precursors specifically, within the bone marrow, and they can be prominent after chemotherapy or a bone marrow transplant, or especially in children. The lowest scoring challenge was a negative challenge in the first mailing, the 2018 A mailing, which had only 41.8% of labs correctly calling the cases negative. Of the positive cases, a majority were within 1 log of the intended percent involvement, though some did have clinically actionable differences. However, overall performance improved with time, as we can see here. The red stars indicate cases with a negative intended result. Performance was sort of erratic at first, but by the end of 2019 had stabilized over 90% correct for that mailing. So this is further evidence from our committee that the proficiency testing model of education does improve performance. To improve performance even more and identify flaws in laboratory methods, we will be debuting, or we actually have debuted this product already, B-ALL MRD wet challenges. As we touched on earlier, wet challenges have more variables than dry challenges. To start with, we're shipping cell lines in some sort of diluent across the world. While high bars for acceptable shipping conditions are in place, there's always going to be some inherent variability on how the PT products are handled. Add this to potential suboptimal processing by the labs, divergent methods, different analyzers, software, reagent manufacturers, among others, we can see why it would be difficult to achieve the intended percent involvement or MRD level. But just because it's difficult doesn't mean we shouldn't address the issue. As much as we wish that all patients would just stay in one system for their care forever, it's not realistic. We need to be able to trust that labs are providing comparable data for patients and for clinical trials. So keep an eye out for this product and likely another manuscript in a few years assessing how this product impacts laboratory performance. All right, finally, I'd like to talk a little bit about how you can become a junior member of the committee and what opportunities it affords. So the CAP accepts applications from May 1st to, I'm not sure when it closes, but it's for the following January. So applications are already closed for January 2021. My successor in the flow cytometry or diagnostic immunology and flow cytometry committee will be Elena, who is a second-year resident. The term is generally 2 years or less if you become board certified before your term expires. To see all the requirements and to apply, sorry, go to the member resources tab at the top of your CAP homepage, and then go down to councils and committees. And then over here on the right side of your screen is a link for volunteer for a CAP committee. The application does take a bit of time, and you do have to do it very far in advance, but it is worth it when you see what you're able to accomplish. What I've been able to accomplish include papers. As I said, this paper has been accepted to archives and it's available online. We are working on our B-ALL MRD manuscript. I've written several chapters of a book that will come out late this year or early next year, The Color Atlas of Flow Cytometry, to be published through CAP Press, edited by Drs. Dorfman, Linden, and Carlin. I get to help assemble PT materials. For dry challenges, that means finding a clinical vignette, putting it together, getting laboratory data, pertinent slides, and then informatively gating dot plots to send out to laboratories. Whereas wet challenges, our lab will pre-test the cell lines, and then either Dr. Linden or I or Elena in the future will gate these to make sure that we are getting the response we want. I'm able to write PT discussions as well, such as this one for an acute myeloid leukemia study. I'm able to have a really good review of AML for myself as I'm writing it for the laboratories. I get to have input on checklist items. I have gotten to write CAP learning modules such as this serum-free light chains, continuing education product or module for lab techs. That was written with Maria Woolrich of the Mayo Clinic. And then I was able to present this at the USCAP conference in March. And then lastly, networking. I have been able to meet a lot of really incredible people and am very happy with all of the new friends I have made from all over the country. These are my objectives that I hope I have accomplished. I would like to thank Dr. Linden ahead of everyone. He has really helped me do a lot. He has guided me in getting these papers published. He has gotten me job interviews. He has done so much, and he's really supported me as a person as well. So I'm very thankful to him. I'd also like to thank the committee because they accepted me with open arms and didn't treat me like just a resident. I really felt like a member of the committee. And then the other folks that I have done papers with or projects with, Dr. Elizabeth Corville, Dr. Mean, and Dr. Jimmy Stewart. With them, I wrote this paper that has been accepted and is pending proofs for the American Journal of Clinical Pathology. This one was a long time in the making, so I'm very proud of it, and keep an eye out for it in the AJCP. And Dr. Amy Karger, who I was able to present a poster with on pancreatitis. And then finally, my co-residents, my family. I love all my residents. You guys are fantastic and very supportive, and I couldn't thank you more for everything you've done. These are my references. And then one last little plug, CAP 20 is coming next month. And for junior members, it is free to register as it's a virtual meeting. And the keynote speaker is going to be Anthony Fauci, which should be very interesting. So if you're able to, it would be great to sign up for that free education. And with that, I'll open it up for questions. Thank you.
Megan, this is Tony Colleen. That was a fantastic presentation, and thank you very much for telling us about your experience as a CAP junior member. I would like to echo your recommendation to other residents to apply for CAP committees. I've chaired several CAP committees over the years, and it's been just a pleasure to have a resident pathologist on the committees. These are, as I think you expressed very nicely, really wonderful opportunities for learning, to meet people in the field, for networking. I would say be open, if you're applying, be open to other committee possibilities than the one that you might have your heart set on, because there's only one junior resident per committee, so these are quite competitive applications. But just to get the experience of being with a CAP, consider applying for other, or indicating that you have an interest in more than just one committee would be my suggestion as well. But great job, and thank you, Megan.
Yeah, and Tony and Megan, thank you. This is Michelle. Thank you again, Megan, for really summarizing how great the CAP junior membership is. It is something that I typically encourage all residents during their semi-annual evals and any other time they come to me with questions about this. We really do strongly encourage residents to become involved. It is a great experience. Hopefully at some point soon we'll be able to go back to in-person meetings. It really is, it's a tremendously great experience, and it's one that has really impacted, you know, my career, and I'm tremendously grateful for the opportunity. So again, I will just second that and say that it truly is a great experience for residents. There's as Megan, as you summarized, there is a bit of an application process, and as Dr. Colleen mentioned, sometimes you do have to be a bit flexible, but I think it's well worth the effort.
I just wanted to add some logistic things because I think that timing is of the essence. So usually the application window is only open for a month. So it opens April 1st and it closes May 1st. You have to reapply every single year. Your application cannot be carried forward. If you're a junior member, some things to consider is you have to have a letter from your program director. So if you're going to apply, I would ask Michelle or Andy April 1st, not wait right until the last minute to ask them, because that needs to be uploaded. The other thing to think about is CAP has rules about when you term. So basically, as soon as you become board certified in pathology, then you become ineligible for junior membership. So if you're AP-CP, you really want to start thinking about applying during your second year or maybe even your first year. And if you're AP or CP only, you want to apply probably your first year. I think that the important thing to consider, as Michelle and Tony said, is think broadly about the committees. You know, autopsy committees heavily applied to, the heme resource committees heavily applied to, but some of the other ones like billing or other areas of CAP may not have as many junior applicants. So think about applying to some highly applied committees and some less common committees, because it'll increase your chance of getting to go. And pre-COVID, we took some really nice trips to Tucson and to Palm Springs, and we've had some nice opportunities to travel 3 times a year. So we'll probably eventually get back to that, but I think it's a good experience. I always wanted to be a junior member, and I was never selected, so it's fun for me to kind of pay it forward and get people from our residency program involved.